Let's move on to the parathyroids. Where'd you get your parathyroid surgery done? UFC? Yeah. Okay, here's the scoop on the parathyroids. They, of course, are the small, teeny, little, teeny glands that sit on the back of your thyroid. They produce parathyroid hormone, PTH, which, of course, helps to control your serum calcium. This is all controlled by the levels of serum calcium. If you don't have enough calcium, then PTH says, I'll get a little from the bone. So PTH goes over and says, let's resorb a little bone, put some more calcium in your bloodstream. So your bone is your reserve, which says to me then, if you have too much PTH, called hyperparathyroidism, what are you doing to those poor bones? Yeah, you're pulling out too much calcium from those bones. So we'll talk about that, but suffice it to say, hyperparathyroidism actually is called bone and stone disease, but we'll come back to that in a second. Okay, so serum calcium levels are tightly regulated. And I mean tightly, not like serum sodium, which is 135 to 145 in terms of numbers. Serum sodium can be a pretty wide range. If you see any increase, I mean any increase in serum calcium, that is not normal. Period. So 10.2 is the highest serum calcium supposed to be, and you have a patient with 10.5. Does that mean that patient should be evaluated? Yes. Don't just blow it off and say, oh, it's just a little bit above it, because they could have hyperparathyroidism. All right, so major function of serum calcium is to exert an inhibitory control over neuromuscular excitability. It's a fancy way of saying helps control your muscles. That's hard to see, but the actual picture here shows you the outline of your thyroids, and then at each pole is a parathyroid gland. These are all big, you all. They're supposed to be much smaller than this, so each one of these is enlarged. Okay, so hypoparathyroidism means you don't have enough PTH, which means your calcium levels are too low. Hypoparathyroidism needs to be adjusted. Your calcium levels need to be adjusted with your total serum level of albumin, and there's a formula we use to adjust that if your albumin is low. Serum albumin is low, the total calcium may provide a misleadingly low indication of what's free. Free, remember, free is the functioning. Too little PTH results in low levels of serum calcium, increased neuromuscular excitability. This is known as tetany. Is this an emergency? Yeah. Calcium levels below 8.4. Patients are confused, complain that their lips are tingling. Lips tingle. And they might have a positive sign of neuromuscular excitability when you do this to their cheek. It's called Chvostek's sign. They go, meaning it is twitch. It twitches. Too little calcium. Twitch, twitch, twitch. A more significant sign that even picks it up a little earlier is called Trousseau's sign. And that's where you take a blood pressure cuff, wrap it around their arm, pump it up. What's the normal hand do when you pump up a blood pressure? Nothing. But if they're low with calcium, they'll go into this, the hand will do this position. See it? It's called Trousseau's sign. It's also known as the obstetrician's hand. So, their hand goes into that position. You know they are hypocalcemic. What do you need to give them? Hello? Calcium. Because their heart also can go into an arrhythmia, and you can die. So, low calcium, thyroid arrhythmia, cardiac arrhythmia. How do we kill a parathyroid? It could be autoimmune disease. It could be the fact that you took out the thyroid and took out all 4 of them. So you need to check those calcium levels. How do you treat? You give IV calcium depending on the levels and the patient's condition, obviously. Okay, how about too much? Primary hyperthyroidism is the most common cause of hypercalcemia and should be considered in anybody with an elevated calcium level. You know, we're doing that now as part of the normal screening. So we're doing calcium levels. We didn't used to. And now we're picking up a lot of people with parathyroid problems, which is good because if you pick them up early, you can treat them early and not get into all the problems with the bone resorption and the kidney stones and all the other things we see when you have long-standing hyperparathyroidism. So, peaks in the 7th decade, that would be somewhere around your 60s. 75% are women. Here we go, ladies. We got the market on this one, too. Women, men equal women before the age of 45. So after 45, it's women, women, women. Major possibilities as the etiology are head and neck irradiation in childhood. And then long-term lithium. So something else to think about with lithium. Not only the thyroid, but the parathyroids as well. Did y'all know that lithium first came out in 1920s as an additive to 7-Up? Yeah. It was the up part of the 7. Right along the time they were adding cocaine to Coca-Cola, they were putting lithium in 7-Up. That's why there was nobody with manic depressive illness until the 1940s when they took lithium out of 7-Up. Alrighty then, so classic signs and symptoms are rarely seen in the United States today because we have early detection of calcium abnormalities today when you get your blood work done. Classic signs, though, are what we call bone and stone disease. You have too much calcium, you got too many kidney stones. In fact, today, if you have a kidney stone, what will we check? Your calcium. Absolutely. We'll also check your PTH. So, bone and stone disease. Too much calcium coming out of those bones causes these areas of bone that look like kind of moth-eaten areas of bone. So, osteomalacia, it's called. All right, symptoms today: weak, easy fatigability, anxiety, and cognitive impairment, kidney stones in 4 to 15%. That's kind of hard to diagnose when somebody says, I'm tired and weak and anxious. Oh, it must be your parathyroid. Who would think of that? Nobody. So then you have to do the blood tests. All righty then, so here's the one that's probably the more common cause of hyperparathyroidism today, is called secondary. And the secondary hyperparathyroid is due to chronic renal failure. And how many patients do we have in the United States today with chronic renal failure? Too many. And why? Diabetes. Absolutely, that nasty disease called diabetes. So secondary hyperparathyroidism, your kidneys can't excrete phosphorus. So as phosphorus remains in the blood, what does the parathyroid say? I got to balance that. You have what's called a calcium-phosphorus balance, what's known as a cross product. Doesn't matter. What it is if your phosphorus is too high, your parathyroid says, I will help by pulling what out of bone? Calcium. So that's why we give phosphorus binders to our renal patients, so we don't get bad bones. Secondary hyperparathyroidism causes terrible bones called osteomalacia. But the good news is we know how to prevent that. But that is probably the #1 cause today. And then, of course, we also have certain tumors that make a PTH-like substance, and that causes hypercalcemia. And the most important thing to know about a malignancy that causes hypercalcemia is that we see this unexplained in the elderly. So you got an 80-year-old with hypercalcemia. It's mostly not the parathyroid. It is cancer. And the most common cancers are lung and GI. So they may have an occult malignancy. Now, if they're 97, are you going to do anything about it? Probably not. You might want to find out where it is. But usually there's a little weight loss going on. There's other symptoms too. Okay, and then of course when your ovary fails, one of estrogen's functions is to inhibit PTH. The ovary's done, primary menopause, ovarian failure. What happens? Calcium starts coming out of bone. So ladies, we got to keep our bones healthy. Okay, so let's move on to your adrenal gland. Adrenal means on top of the kidney, added on to the renal gland. Adrenal. So it's up here on top. Here's the kidney here. There's a little bit of fat tissue shoved in, and then there's the adrenal gland. All right, now we have different sizes. Just want to show you. Adrenal gland too small, adrenal gland just right, and too large. So this is atrophied adrenal gland, a normal size, and a hypertrophied adrenal gland. Too big. So you've got two parts to the adrenal gland. You've got the middle part, which is called the medulla, and you've got the outer part, which is called the cortex. I will briefly tell you about the adrenal medulla. It's what produces your catecholamines called epinephrine. Epinephrine actually also got its name from being on top of the kidney. Epi is on top of the nephron. Nephros. So epinephrine. Its other name, if you were named in England, it was called adrenaline. Comes from the adrenal gland, from within the adrenal. So if you go to jolly old England, what do you call it? Adrenaline. If you live in jolly old Kankakee, what do you call it? Epinephrine. Same thing, just different countries. So this is responsible for your fight-flight response. Epinephrine, norepinephrine, you know what that is. You visit Barb at 2 o'clock in Chicago, you take a wrong turn, 4 flat tires, and your transmission falls out of your car. You're in the wrong part of Chicago. What's going to happen to you? You're going to die. But shortly before death, you're going to say, oh, look, honey, there's a whole gang coming to help. Isn't that sweet? So you're going to realize you're in trouble. So what happens? Boom, 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 boom. Out comes norepinephrine, epinephrine, the fight-flight response. That's your adrenal medulla. Fight-flight response. You're going to put out lots of epinephrine. It's going to bump up your sugar because your sugar is going to give you energy to run away. Your pupils are going to dilate because you're looking in all directions to see which way you should run. Your blood pressure's up. Your heart rate's up. Your bronchioles are dilated because you're sucking in air as fast as possible so you can run as fast as possible. Your large arteries to the arms and legs are going to vasodilate so you can run. Vessels of your skin are going to constrict so you're very pale while you're running. Your hair on the back of your neck and arms stands up. Why does it do that? Because 10,000 years ago, we were covered with hair. And if it stood up, it made you look bigger and more threatening. So those 3 hairs on your neck are not going to scare a gang away, trust me. All right, and what do your bowels want to do? They want to evacuate. However, you have a mother, and it's called your frontal lobe. And what does she say? You slam that anal sphincter shut. If I have told you once, I have told you twice, do not go to the emergency room with dirty underwear. So how do you run? That's the fight-flight response. So your biggest stress of the day is getting out of bed. This is when everything comes out for you to get the sugar, your blood pressure up, get your heart rate up, get some oxygen to your lungs, get your old tired butt up every morning is basically the fight-flight response. So it's just part of your daily 24-hour clock. So heart rate goes up, blood pressure. This all starts pumping out y'all around 4 to 5 o'clock in the morning. Your adrenal gland wakes up and says, okie dokie, this is your alarm clock, starting to get you up. Also, your liver releases all this clotting factors. Your platelets are stickier due to your high glucose. Your inflammatory mediators are highest in the morning. You are basically one big heart attack waiting to happen. So, how can you avoid a heart attack? Don't get up. Absolutely. You call in to your head nurse and say, I am avoiding a heart attack this morning. I feel one coming on. I think I'll stay in bed. I'll be in around noon. Right? That was your last day on the job. Another acute early morning stress is driving to work. Pick a lane, jerk face. So, I'm surprised more people don't have heart attacks driving. He seems like you. Alrighty, so that's the inside of the adrenal gland. Now let's talk about the outside, and that's called the adrenal cortex. Produces 3 different kinds of substances, one of which, of course, is the most important, and that's known as cortisol. That is your hormone of stress and more chronic stress. Certainly it's produced acutely, but this is the hormone that you use day in, day out, to boost your sugar. So it's around all the time. Of course, in the mornings when you see it highest because your sugar is highest in the morning. Your mineralocorticoids, called aldosterone, helps you to regulate water and salt balance, and potassium. That has nothing to do at all with your pituitary and hypothalamus. Your aldosterone is regulated through renin and angiotensin. So that whole process right there is your blood pressure regulation. This whole process here, renin, angiotensin, aldosterone, is set on a little slightly higher uptick in about 70% of the people in the United States who have hypertension. So that system tends to be a little bit hyper in 7 out of 10 people with high blood pressure. And that's why we choose drugs that block this system and block angiotensin. 7 out of 10 times people are going to respond to these drugs. They're called ACE inhibitors. So a very important group of drugs to stop your blood pressure from being high. And then the last hormone produced by your adrenal cortex are your adrenal androgens. Ladies, this is where we get most of our androgens from. You get a little bit from your ovary, get some from your ovaries, but also you get your androgens, your testosterone, from your adrenal gland. Now, guys, you get testosterone from your adrenal gland too, but your major source is your testicles, of course. So we get a couple of sources here giving us a little androgens. Ladies, what does androgens do for us? They give you energy. They also give you sex drive, libido. You don't have enough androgens, you're tired. You're also not interested in sex. Estrogen doesn't give you sex drive, it's androgens. So a lot of times when we lose our ovaries and we lose a source of our androgens, like, oh, I'm so tired. I don't have any sex drive either. It's that testosterone loss. So if you've lost your sex drive and you still love your husband, like, oh, I love him to death, but I just don't have any interest in having sex with him, then get your doctor to give you some testosterone. Just a little dab will do you. And you can combine it with estrogen if you want. It's called Estratest. And I'll guarantee you within about 2 to 3 weeks, probably sooner than that, probably 7 to 10 days, your sex drive will come back with a vengeance. You'll be looking at that plumber saying, you know, he's looking off. Look at that butt crack. I am really... Call your husband, you better get home fast or the plumber's going to... So, all I'm saying is, why live another 30 years without having a healthy sex life? No sense in it. Unless you don't want it. I'm not telling that you have to do it, but if you're really... A lot of women say, I don't want to have sex with him. Well, you love him? Well, no, but I just don't want to have sex with him, so why would I want to stop? And the other women say, we've had a great sex life, very healthy sex life, and bingo, I lost my ovaries, now I have nothing, not even thinking about it. Then you should think about the testosterone. Works wonders. Okay, then. And again, it's not enough to make you masculine. We're not giving you enough to give you a full beard. That's attractive. Okay, so let's talk about too much cortisol. Excess cortisol. What are the clinical features? Plethoric. You get a big old red face. Your face turns red. Central obesity. Cortisol moves fat toward the center. Fat toward your face. So what does your face start to do? Get round. Yeah, we call that a moon face. Catabolic hormone breaks down all your skeletal muscle. So now your skeletal muscle is breaking down, so your arms and legs get skinny. You move all that fat towards your middle, so now you got a big belly and a round face and skinny arms and skinny legs. You look like an olive with 4 toothpicks. With a pimento as a head. All those amino acids from the proteins are used for gluconeogenesis. High blood sugars lead to impaired glucose tolerance or actual diabetes. So patients with high cortisol, which is called Cushing's, right? Cushing's disease or syndrome, and I'll tell you the difference in a minute. Aldosterone-like properties. We can also see that cortisol then will cause sodium and water retention and potassium excretion. So what happens to your potassium? Goes low, you have high blood pressure, and you have hypokalemia. Can that be a problem? Does potassium play a role in cardiac conduction? Yeah. All right, so then, of course, too much excess cortisol, you have menstrual irregularity and erectile dysfunction in men. Osteoporosis moves calcium out of bone. Protein breakdown in the skin leads to thin skin over the abdomen, and you get all these stretch marks, and they're not the normal color. What's the normal stretch mark color, ladies, when you've had babies? White, silverish, whitish, kind of matches the skin color-ish, depending on your skin color. These are purple. They're kind of reddish purple. And the reason they're reddish purple is because the skin is so thin, you're looking at the capillary network. So it's pretty classic, purplish stria, stretch marks. Big red face, moon face, buffalo hump, all the extra fat goes slapping right there on the back of your neck. As if you're not pretty enough with a moon face and a big belly. Now we're going to take a big piece of fat and whack it on the back there. It's a fun day in endocrine clinic. How's that moon face? Fine. How's that jaw, that Jimmy jaw? That's your acromegaly, that big old jaw sticking in. All right, anyway, so. All righty, tendency to bruise easy. Poor wound healing, hirsutism, frontal alopecia, meaning you're starting to lose your hair. This is just a terrible excess cortisol. You got to have a high index suspicion, and I'll tell you that in a minute. Then you also put some fat in between the scapula, that's your buffalo hump, and you also put some fat here. You know, you generally, if you get fat, if you gain weight, which many of us have as we've gotten older, you usually don't put big, huge hunks of fat right here above the scapula. So when you do see a fat pad here, you got to think of cortisol excess right here. A lot of times you get, you know, you can still feel those bones. There is a bone there, isn't there? Yep. Yeah, there we go. So there's a big piece of fat above it is a problem. Little acne, depression. Cortisol is a powerful appetite stimulant, so you are craving simple carbs. That boosts insulin and promotes fat storage. So how pretty is excess cortisol? Not. So we call this hypercortisolism, Cushing's disease, but there's only one definition of Cushing's disease, and that's if your problem is secondary. Secondary meaning where? Pituitary. Thank you. You get an A+. So you have a pituitary tumor producing too much ACTH. Cushing's disease, named after Dr. Harvey Cushing, the father of endocrinology. He's back in the 1800s somewhere. He's not alive now. Okay, but if you have what's called Cushing syndrome, that's any other cause of hypercortisolism. So Cushing syndrome, what if you're taking too much prednisone? That would be what? Cushing's syndrome. What if you have an adrenal tumor producing too much cortisol? That's called Cushing's syndrome. And you're probably thinking, so what? What difference it makes is where are you looking for this? So if it's in the pituitary, it's the disease. Anyplace else, it's the syndrome. All right, then you can also have cancers producing too much ACTH. That's called a paraneoplastic syndrome, ectopic production of a hormone. And usually it's a lung cancer. Those lung cancers are pretty interesting, you all. Bad, but they're interesting. Okay, then. So here we have a patient with Cushing's. I don't know what it is because I don't know if it's disease or syndrome, but he's got the facial plethora, the roundness to the face. How about her? Is she pretty much Cushionoid? Just looking at her, you know, she's either on prednisone or something's going on, and she is. She's a kid with renal failure. She's on high-dose prednisone. All right, so these are all the things we're going to look at as far as the feedback mechanisms. Cushing syndrome is difficult to recognize early. Why? How many obese, mildly hirsute, hypertensive, glucose-intolerant women with irregular menstrual periods does a primary care practitioner see? A lot today, you all. I mean, a lot of us have gained a little weight, maybe have a little more hair on us, and a little hypertensive. Our sugars are kind of running about 110. Our periods are wacky because we're in our 40s. So One of the last things most primary care physicians think about is Cushing's. And then you start doing some blood work. You start realizing, okay, this could be when we start looking at some of the other problems they have. Or you can do a very simple test. It's called dexamethasone suppression test. What's dexamethasone? It's cortisone. It's just a very strong dose. It's the strongest of all the cortisones, dexamethasone. So if you give it at 11 o'clock at night, what do you expect to happen? So dexamethasone suppression test, you are going to try to suppress ACTH from the pituitary gland. Draw an 8 a.m. plasma cortisol level. Level less than 5 excludes the diagnosis. Okay, treatment. Where's the problem? Barb, I got a pituitary tumor producing too much ACTH. So what am I going to do? Probably take it out. It's big. Okay, if you can't treat it surgically or don't find the source, then we can use inhibitors of steroidogenesis, meaning we can stop the cortisol production by using a drug, interesting drug, an antifungal drug called ketoconazole. Or a metopyrone. I don't know if you ever heard of this one. Some of you have, yeah. If you have to, it's because of the adrenal glands, then you might have to take out the adrenal glands. If you take out the adrenal glands, what must you replace? Give me 3 things. Cortisol, aldosterone, mineralocorticoid, and testosterone. So if those are removed, then you're going to have a person with primary hypocortisolism. So you have to give them back.
But this is not on bilateral, is it?
If it has to, sometimes it has to be. Sometimes both of them have adrenal adenomas. Yeah. Sometimes only one, but actually we have seen both of them. Okay. Addison's disease. What president of the United States had it? Kennedy. Everybody knows that. Interestingly, all the different things our presidents have had. Remember Jimmy's Hemmies? I'll never forget that. That was the funniest thing I've ever heard. When Jimmy Carter told us he had hemorrhoids. That was a medical emergency. Anyway, they've all had something. So, primary adrenal cortical insufficiency. John F. Kennedy, not enough adrenal cortical hormones. He had decreased cortisol, decreased aldosterone, decreased testosterone. What was he on every day? Prednisone, testosterone, and Florinef, which is the mineralocorticoid. Every day. And when the Bay of Pigs hit, stress response, they had to pump up what? His prednisone. When there's a stress response, you're not just taking 5 milligrams, 7 milligrams a day. You've got to pump it up, usually 2 or 3 times what it is, to get you through the stress response. You might remember the Bay of Pigs? Think we were all going to be blown out of... we were doing all those drills, going under our chairs in school. It's like, oh my God. All right, so feedback to the pituitary. What happens? ACTH, high, 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 trying to beat a dead horse. Okay, so the big molecule containing pro-opioid catecholaminerone we talked about this morning. ACTH, kick, kick, kick as hard as we can. Dead, dead, dead adrenal gland, but it's kicking hard. Then out comes MSH. That's what causes people with Addison's disease to have the darkening of their skin. He always looked tan. Wasn't because he was laying out on the White House roof. It was because he had this high level of melanocyte-stimulating hormone, making his freckles stand out. You tend to see the darkness in the darker areas. His lips were darker. The buccal mucosa tends to get darker. Freckles are darker. Scars get darker. So he tended to always look like he was tan. So there's a different look at Addison's hands. Darker versus the normal color. So they look it's a little more orangey looking. It's not really a pretty brown color or pretty darkening. A little bit more orangey looking. So your signs and symptoms of Addison's are low blood sugar, not enough cortisol. Oh man, I'm really tired. Lose weight, weak, low aldosterone. So what's your blood pressure? Low. low blood pressure, low blood sugar. In fact, you get rid of all this low sodium in water, and then your potassium is retained. So now you have hyperkalemia. Is that a medical emergency? Yes. What does that do to your heart? Stops it. Something called peaked T waves, before they then develop an undulating pattern, and then you die. So hyperkalemia is a threat as well. So if somebody says to you, that patient in the emergency room has acute adrenal insufficiency, does that tell you it is a medical emergency? Yes, yes, or yes? Yes. And one of their biggest emergencies, you all, is hyperkalemia, accompanied by hypotension and hypoglycemia. They need sugar, they need fluids, and they need something to stop the potassium. Okie dokie. Decreased, and at that moment they're also telling you, I don't have any libido. Well, let's take care of your heart first. But it's my libido I care about. I know. So all that increased ACTH tries to stimulate that dead adrenal cortex, increase pigmentation, blah, blah, blah. All right, so there he is, John F. Kennedy. He was always 10. He was always happy. Why was he so happy? Because he had Marilyn Monroe in the bedroom. Wouldn't you be? Good Lord. He didn't seem to have any libido problems. Because he was on testosterone shots. Wham, wham, wham. Doing fine. Happy birthday, Mr. President. What can I give you for your birthday? All right, then. So, what are we going to give old JFK? Besides Marilyn. Prednisone. And again, I'm not telling you how. This is just showing you some of the doses we will certainly start. Lower maintenance dose. Might have to pump it up again during times of stress. Fludrocortisone, which is Florinef. That's what keeps that's aldosterone, to keep your blood pressure up. And then, of course, a little testosterone. Pills, gels, shots. He was on shots. Just an FYI real quick here. In the order of steroid potency, dexamethasone is 25 times stronger than hydrocortisone. So this is just in order of potency, what you use in patients. Prednisone is only 4 in terms of this is really high dose, you all. The dexamethasone is the really strong corticoid. All right, so you have acute adrenal insufficiency. What are we going to do? Usually occurs in people with chronic adrenal insufficiency who undergo some form of significant stress. That would be MI, surgery, trauma, the Bay of Pigs, sudden withdrawal of steroids. Any patients on larger doses, which would be greater than 20 milligrams a day, for 2 weeks or more, has a potential for long-term suppression of the hypothalamic pituitary adrenal axis. So if they come off those suddenly, what can't you start back up quickly? That whole production process. So you never stop steroids immediately. You do what with them? You taper them. 20, 20, 20, 15, 15, 10, 10, 7.5, 7. I mean, you do it slowly over a couple of weeks, depending on how long they've been on them and how high it is. Now, sometimes we'll give people a quick burst of steroids for something. And that little burst doesn't usually need to be tapered, you all. But when you've been on steroids for greater than 2 weeks, what should you do? Taper them. I remember being on steroids once for a nasty case of poison ivy. It's my fault. I was drinking too much beer. There was no toilet in the immediate vicinity of the baseball field. So I zipped back into the woods, squatted down, right in a poison ivy patch. This is so funny because, you know, poison ivy is not immediate unless you're really allergic, and then you just look at it and you break out. But I'd never in my life had poison ivy. Sat down, peed, got up, played the rest of the game, went to my parents' house for the weekend. This was when I was in graduate school. And about 2 days later, I woke up and I was like, oh, man, wow, whoa, what's going on here? I said, Mom, you got bed bugs. I don't have bed bugs. Yeah, so I went back to school. It was in graduate school. I went back to school, and a good friend of mine was an immunologist. And I snuck over to his office, and I said, what the heck's going on here? He looked at me. He burst out laughing. He said, that's a classic case of peeing in the bushes, poison ivy. And he said, and for your punishment, medical students, get in here. I want to show you. And I was actually also a professor of nursing at the time. So here he said, here's our professor of nursing, Barb Bancroft, with poison ivy of the butt due to peeing in the woods. Oh, I could have killed him. Could have killed him. He got the most pleasure out of that. Anyway, so the only thing that really helped was some steroids. So just a quick hit. But it was over 10 days. So we started out with a 10, 10, 10, 10, 5, 5, 7, 7, 7, 5, 5, 5, 2, 2, 2, 1, 1. So you can do that as well. Okay, then, if you're in big trouble, then we're going to give you IV hydrocortisone. Okay? So, again, greater suppression of the HPA axis occurs when the doses are taken in the evening. So if you want to shut that whole axis off, then you take it in the evening. The morning doses mimic your usual biological rhythm. Doesn't that make sense? Because when is your highest sugar? In the morning. Okay, so recovery of this axis may take from a few months to a few years, depending on how high of dose you've had over these years. So if our patients with lupus, you all, I see women on 100 milligrams of prednisone a day with some really severe lupus cases. So that particular group of women, it might take them how long to get off that? A year. You've got to really taper it slowly. All right, so we switch them by weaning. There's ways to do this, but that's just one of the ways. All right, primary hyperaldosteronism. This is when you're producing too much aldosterone, usually due to adrenal tumor. All right, too much aldosterone, think about what that would do. Retains sodium and water, so what will your blood pressure be? High. And excretes potassium, so what will your potassium be? Low. Hypertension, hypokalemia. So I've told some of you this story before. We had a little girl come in to our unit, and she kept getting pneumonia. Pneumonia. She came in 5 times with pneumonia. And every time she came in, it was every 21 days. 21 days, gave her penicillin, sent her home. 21 days later, crackles in the lungs, penicillin, got better, sent her home. So finally, on the 3rd time, I actually said in rounds, I was a head nurse, peds, I said to the doctor that was the attending that month, you know, there's a pattern to this. And he went, and walked off. I said, okay. But most children don't come in every 21 days with pneumonia, y'all. That's just bizarre. So I was too dumb to know what it could be, but I just knew that it was 21 days. 3 times, 21 days. So finally, on the 5th time she was in, one of the medical students in rounds raised his hand and said to the same doctor, there's a pattern to this. He said, oh, excellent observation, son. You wouldn't believe how fast my arm went. I said, yeah, this is the 5th time she's been in every 21 days. Anyway, they had done her white count, and the white count was always high. So they assumed she had pneumonia. It was bacterial. They gave her what? Penicillin. She got better in 3 days, must have done the trick, sent her home. Finally, since it was every 21 days, times 5 times, they did a differential. Had never done a white blood cell count differential, just the total white count. Found out she had 22% eosinophils. 22% eosinophil says you're either having allergies or you're having parasites. Now, you don't get allergies every 21 days, so most likely she had what? Worms. She had parasites. All right, believe it or not, I'm getting around to something. So, why would she have parasites? Ask her, worms is what she had. And the worms she had were worms that had gotten into her body, lived in her liver. And every 21 days, they released their larva. The larva went through the lungs and set up a pneumonitis. Yeah, crackle, 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 a little bit of a fever. And then 3 days later, they left the lungs, just in time for the penicillin to work. Penicillin wasn't working at all, you all. Did nothing. Okay. Why do you have worms, Carlotta? Was her name. She was so cute. Why do you have worms? Well, she's only 4. She had no idea why she had worms. So talked to her parents. Her mother said, I don't know why she does this, but every day she runs under the house and she eats dirt. And along with the dirt, she eats dog poop. Yeah, she loves it. Dirt and doo-doo. Favorite snack. Love it. Little glass of milk, a little more dirt, a little more doo-doo. So what was she actually eating? Parasites. But she was doing this because children have pica for a reason. She had pica, you all, and she's eating dirt and doo-doo. She refused the cookies that went with the milk. She would rather have dirt and doo-doo. So obviously she's missing something. Children who have pica are missing a nutrient. Okay, so no one could figure it out. Even the brilliant endocrinologist couldn't figure it out. So the nutritionist said, well, what's in dirt and feces? Potassium. She had a potassium wasting disease called Conn's disease. She had a very small adrenal tumor, which is rare in children, you all. But she had it. She was wasting potassium, and the only way she knew how to get potassium was to eat what? Dirt and doo-doo. Brilliant. You say, well, how'd she know? The brain knows. The brain tells you what to eat. In fact, it's so fascinating. If we give children, a 2-year-olds, a choice of food, they've never been to McDonald's, which is not true anymore in the United States. They go to McDonald's on their way home from the newborn nursery. But generally, they've never been to McDonald's and gotten the taste of fast foods and fats and all that stuff, and you put out food on a platter, they will actually pick what they need. They'll pick a very healthy diet. So her brain was saying, you need some potassium here, and the only way you can actually reach something is probably reach for the dirt and the doo-doo. Poop has a lot of potassium in it, you all. That's one way we get potassium down, is to give you enemas, K-oxalate enemas. Remember that? Sorbitol, K-oxalate? Out it goes. Okay, so the nutritionist said, it's potassium. Sure enough, they tested her, and she had Conn's disease. So all you have to do is remove the tumor and, of course, give her some potassium in the meantime. So very simple fix. Boom. If you see anybody eating dirt and doo-doo, check what level? Potassium. If they're an adult, they need Resperdal. It's not pica. All righty, so fascinating little story. She never came back again. It's too bad. She was so darn cute. Oh, just turn that off. Okay, so, we're here at the ovary again. So we've already done this, you all. Primary ovarian failure means what? No estrogen. Ovaries die. You also don't have enough androgen. So zippity-doo-dah to your libido. Also gives you a little muscle mass. What should you start doing when you hit menopause? Weights. Yeah. You can do them earlier if you want, but why? Wait till you need to. That's menopause. Alrighty, so estrogen deprivation. Estrogen has over 300 functions. The most notable symptoms of deprivation, of course, are your vasomotor symptoms. Feeding back to the hypothalamus and saying, I don't have enough estrogen. So the hypothalamus says, well, let me help you. Starts putting out all sorts of things, and one of those things is temperature dysregulation, vessel dysregulation. You're hot, you're sweating, temperature's up and down. Okay, we did that already. I love this cartoon. 2 chickens. Menopause is easy. After you stop laying eggs, they eat you. All righty then. Then we got the old perimenopause, which we've also mentioned. Ovaries on a roller coaster. Variable menstrual cycles. FSH is doing what? Going up, trying to beat an ovary that's not doing its job. Saying, come on, you're not putting out enough hormones. Let me try to stimulate you. So FSH is rising. Persistent elevations above 40 or greater than 50, over the age of 50, says your ovary is dead. That's it. Party's over. But as I said earlier, you really don't need to do this to diagnose this in most women. In young women who are having trouble with ovulation, they may go through the menopause early. There are women that go through menopause as early as 30. That's rare, and it's usually hereditary. There's a gene called the FOXL gene, F-O-X-L, where it's an early menopause gene attached to a gene that makes you born with droopy eyelids. I know this is crazy, you all, but it's true. So the same gene that makes you have congenital ptosis of the eyelids, meaning you always look like you're sleepy. You don't have myasthenia. This is from birth, is a gene that's tied to early menopause. Now this is funny. Let me tell you, and then I'll tell you, get your question. A friend of mine that I went to undergraduate school with was named Leslie, and she was born with congenital ptosis. Now, we never knew this in college. We knew she had droopy, and her nickname was Droopy. How original was that? She'd sit in class all day looking like this, and the teachers would say, Leslie, wake up. And she'd say, I am awake. But her eyes were just always so droopy. So we went off our merry ways after graduating from college, and I read this article on droopy eyelids and early menopause. And I'd gotten a Christmas card from Leslie all these years, and she had a daughter. And her daughter had the same droopy eyelids. Read the article. I called her up. I said, Leslie, it's Barb. And she said, hi, Barb. I hadn't talked to North Carolina. I hadn't talked to you in so long. How you doing? I said, I'm fine. She said, well, why are you calling? I said, when was your last menstrual period? She said, you know, you haven't changed since college. You're just as crazy as you ever were. Why do you want to know? So I said, well, tell me, come on, when did you stop having periods? She said, I stopped having periods at 30. I said, no kidding. She said, why are you so excited about that? I said, how old's your daughter? She said, she's 18. I said, well, you better tell her to start having children right now. She said, no, I'm not going to tell her that. I said, why are you, she said, why are you telling me that? I said, because I just read an article on droopy eyelids and early menopause, and she will stop her entire ovulation by the time she's 30. And a lot of girls are waiting to have children now, you all. Not everybody. When I graduated from college, everybody was married and had kids within 6 months of college graduation. In fact, they were walking down the aisle with a little bat. So it was just 21 years. Everybody was married and having kids. Now we're seeing an entirely different generation. So if you got somebody you know with droopy eyelids and they say, I'm going to have kids and I'm 35, say, no, you're not. Period, you're not. So kind of interesting. I don't know why the droopy eyelid gene is with the early menopause gene, but it is. So you see somebody at the mall, young girl. Excuse me, miss. Do you have a boyfriend? Well, then start having children. Alrighty then, so we all know those vasomotor symptoms, a hot flash, lack of sleep, grouchy, and you're grouchy not because of menopause, because of the lack of sleep. It has nothing to do with hormones making you grouchy. If your husbands didn't have sleep for weeks on end, they'd be grouchy too. So, vaginal dryness is like the Mojave Desert. Calcium is leaving the bone at a rapid pace due to the unopposed PTH because you don't have enough estrogen, so all of a sudden your bones are falling apart. And here is the newest information. Listen up. FDA has approved low-dose estrogen for certainly bones. But every single gynecologist today certainly has read the newest information. When you're having symptoms around the age of 50, 51 is when you should start estrogen. And we're talking about low-dose estrogen, not 6.25 or 0.625, not 2.5 of progesterone. We are going so low, you all, it's half that dose. What we used to give is what was called the normal dose, cutting it in half and starting you around the age of 50. This is now accepted clinical practice. Your risk of breast cancer is absolutely nil starting it at this time. We're going to reevaluate you in about 3 years and see if you still need it. We are recommending that you only stay on estrogen and progesterone for about 4.5 to 5 years. And the estrogen by itself, if you don't need the progesterone, estrogen by itself, you can stay on it for at least 7 years. And then we reevaluate you again. So the pendulum is really swung in the opposite direction of that stupid women's health initiative that came out in 2002 and scared every woman in the world about estrogen. Because we know that low dose basically has no long-term side effects. So that's the latest information about hormone therapy. Now, if you've had breast cancer, the answer is no, we're not going to give you hormones. But that's probably one of the only contraindications. The other one is, did you clot on birth control pills? If you had clots on birth control pills, we probably won't give you hormones either. But then again, those clots were due to very high dose estrogen in those old birth control pills. So the new information is, don't be afraid to use estrogen. The breast cancer risk is minuscule. minuscule. And we'll reevaluate you after a few years. And plus, we're not going to give you your new prescription every year for your hormones until you've had a mammogram. So we're not just going to give this blank carte blanche. We're going to make sure you get your mammograms and pick it up early. Is breast cancer curable today if picked up early? Yes. So what's the survival rate with breast cancer today? Close to 90%, you all. And that's even mixing in all the stage 4s with all the stage 1s. So we've really got an amazing survival rate for this disease today. All righty then. So I do want to mention endocrine disorder of young women. This polycystic ovary syndrome. So I'm sure you're familiar with this. It was first described in 1922 by 2 French physicians who wrote a paper called, I can't say it in French because I never took French, but the translation was The Diabetes of Bearded Ladies. What does that tell you about polycystic ovary syndrome? High blood sugar and high androgens, because you have a lot of facial, not everybody has a lot of it, but facial hair, coarse dark hair on their arms. So they tend to be hairier. And they also tend to have glucose intolerance, diabetes. So that was the first paper ever written, The Diabetes of Bearded Ladies. 5 to 10% of all women today in reproductive age group have polycystic ovary syndrome. Be aware of it. Look for it. Think about who's at high risk. So these are all criteria for the diagnosis of this. We don't need to go through all of them, but they're basically all the same, you all. If you've got too much androgen, you're not going to have normal periods. So what usually brings them to the doctor? Anovulatory periods, no periods. Maybe 4 periods a year, maybe less. So they don't have enough ovulation. All of these have very similar things. Hirsutism, facial hair, chin hair, lots of hair around the pubis, and then androgen excess. Again, we do look at ultrasound. Most of these young girls have polycystic ovaries. Lots of cysts in those ovaries. Okie dokie. The lab test we do is called an LH to FSH ratio. They have much higher LH than they have FSH. This leads to excessive testosterone. All right, so we don't need to go through all this, but suffice it to say they have a high level of testosterone, high level of insulin resistance, which is making their sugars go up. So look at the things that we see as a clinical presentation. Most of them have hirsutism, lots of hair, male pattern alopecia or acne, oligomenorrhea or amenorrhea, abnormal uterine bleeding, polycystic ovaries, obesity, and 50%. And then most of them are not fertile. In fact, many women are diagnosed when they come to fertility clinics. I can't have babies. I don't know why I can't have babies. And bingo, they start looking at these ratios, and LH to FSH, and they then look at the ovaries, and they have cysts in them. So polycystic ovary syndrome. Complications, insulin resistance, diabetes, 10 times higher in women with polycystic ovary syndrome. Impaired glucose tolerance, obesity, higher rates of heart attacks, increased risk of endometrial cancer due to unopposed estrogen stimulation. So this is a syndrome we want to treat. It's not something just to blow off. All right, so do you want to become pregnant? That's our first question. Well, yes, that's why I'm in a fertility clinic. Okay, then. That makes sense. We'll get some urine from a postmenopausal nun in Italy. We'll send it over FedEx. So we can certainly boost your fertility. And we also put you on a drug called metformin. Metformin, you all, is the drug of choice today for polycystic ovary syndrome because it increases your menstrual cyclicity and ovulation, but it also reduces your insulin resistance. So then your blood sugars will fall. Then we also see that the androgen synthesis will also fall with that. So the first line therapy today for polycystic ovary syndrome is metformin. Now here comes the next question is, do you not want to get pregnant? Well, we certainly won't give you the urine from the postmenopausal nuns. But if you start on metformin, you will start ovulating, so you'd better also be put on birth control pills if you don't want to get pregnant. And we'll usually use birth control pills with an anti-androgen component, which will help to do what? Get rid of your facial hair. So it's simple to treat, but we just truly want to make sure we get everybody treated. The oral contraceptives offer endometrial protection, because there's a combination of hormones in them, so you don't have to worry about the actual stimulation. All right, any questions? Have a high index of suspicion, you all, for this. All right, so there's the drug of choice, metformin. Got so many uses for this drug today. It's also the #1 choice of drugs for diabetes type 2, but there's lots of other uses that we'll hopefully get to. Do men's testicles ever die? Not often. Is there such a thing as male menopause? No. They might be moaning and groaning and whining, but it's not because their testicles are dead. Do their testosterone levels decline over the years? Yes, but rarely to 0 like our ovaries. So men don't do the primary caretaking. I'm sorry, guys, I know you do contribute. Not much. Well, I changed a diaper once. Yeah.
One fellow said people that are having children at 40 and 50, he says by the time they're old enough to start playing t-ball, there's not enough disability parking lots.
For all the fathers that are disabled.
It's really hard to double Dutch jump rope on an oxygen tank.
Well, we're seeing that too. So anyway, so old guys can have children because they're not the one taking care of the babies. They're just there to do what? Be the sperm donors. Yeah. All right, so your target organ, the testicles are high. Testosterone's highest in the morning, 9 o'clock. 9 a.m., testosterone has peaked. Primary testicular failure is rare, as I mentioned. Secondary testicular failure would be what problem? Pituitary. So, can men have tumors of the pituitary? Of course they can. Can they have had radiation to the pituitary? Of course they can. So, yeah, there are all sorts of things. And then rarely would we see tertiary testicular failure. Now, Klinefelter syndrome, again, is the XXY. This is not uncommon, you all. Just people don't pick it up. And one of the things they do pick it up is when these guys are trying to have children. And they have trouble sustaining erections because they don't have enough testosterone. And do you know how many young men in their late teens try to kill themselves because they're having trouble with having erections? And they finally get into the doctor, and the doctor, because they've tried to kill themselves, and they then do a testicle exam, and they're very hard, small testicles in Klinefelters. And then all of a sudden, fortunately, we've saved their lives, and we can start giving them what hormone? Testosterone, yeah. And they say, oh my God, I can't believe I was going to kill myself over this. Well, they never picked it up earlier. So this is something that's not that uncommon. High rate of suicide attempts. And these are young men that won't take their shirt off in gym because they got breasts. So where are the pediatricians here picking this stuff up? Well, one problem is how many teenagers go to the doctor. So there's sort of a give and take on this one. All right, how about the male with breasts? Look at these breasts. This is a male that is on Lupron for prostate cancer. So this can cause feminization of men. Gynecomastia, could it be grandma from Guatemala? We had 2 kids that had breasts. Grandma from Guatemala was giving them lavender to calm them down. They were 2 young boys, 7 and 9. Came in with C cups. Like, what? Talk to the parents. Again, how would you think? Testicular tumor maybe? Pituitary tumor maybe? Maybe they had something wrong with their hypothalamus. Something was going on. Talk to the parents. Are you giving them anything? No, we don't give them anything. They're not on drugs. Finally, Grandma from Guatemala walks in the door. She says, well, I've been giving them this concoction I made because I thought they were too hyperactive. They are 7- and 9-year-old brothers. What do? fight. They're boys, rambunctious, rumble, tumble. But Grandma thought they were too rambunctious, so she was giving them a concoction. Lavender is a potently estrogenic compound. Ladies, it will not give you a C cup. Stop writing it down. C cup. It will give your husband, you'll be fighting with your husband over the bra on Friday night, but not you. Could it be a feminizing tumor of the testicle? Could it be drugs that boost estrogen? Cimetidine blocks testosterone, makes you get breasts. Aldactone, same thing. Ginseng, for energy, gives men breasts. Female hormones. Why would a man take female hormones? You don't typically do it because they want to, but if women are using Premarin vaginal cream as their lubricant because their vagina is dry with the vaginal cream, let's have sex. The Premarin vaginal cream can cross the male urethra and feminize your husband. Yeah. Yoo-hoo! So now they got breasts. They're fighting with you over the Wonder Bra on Friday night. Their estrogen is so high, their testicles about this big. Penis is about this big. All of a sudden, you have feminized your husband. Now that's a thought. Honey, what's that cream you put in every night? Oh, nothing, darling. Just Next is, honey, what's that cream you put in every night? Can I borrow your negligee? All right, so treatment for prostate cancer. Obviously, we're changing the hormonal environment. And then marijuana. Whoa, this is potently feminizing. So if you got teenage boys that are smoking on the token on the whatever all the time, and they're developing breasts, it's because they're smoking too much marijuana. Now, you can rag on them all you want. Oh, my God, it's terrible for you. It's going to kill your brain cells, going to kill your lungs. They don't care. You tell them they're going to be wearing a bigger bra than their girlfriend for the senior prom. They will care.
Also, the ladies have a problem with the facial hair.
With marijuana?
Also the hair on the back.
The head on the back? Yes. So, you know, a joint or two is not bad for you, but when you're smoking all the time... I could never do it. I choked. I tried it in college. You know, when I went to college, we were trying all sorts of drugs back in the 60s and 70s. You know, I was just part of that whole time. But I couldn't do it. I was like, I hated it. Didn't smoke in the first place. So give me a bottle of Jack Daniels. That was much better. But anyway, so I still know people from the 60s that are still smoking marijuana. They're in their 60s now, and they're still smoking 4 and 5 and 6 joints a day, and they've never gotten a job.
Yeah. They have the money.
Oh, but they say they're going to. You know, I'm going to start a business one day.
Yeah.
Well, you're 62, you better get started. It's one of the biggest anti-motivational drugs in the world. You don't want to do anything. Except do what? Smoke marijuana. Yeah. Bad for you. Okay, and then obesity makes you got big breasts, guys. Increases your estrogen, circulating estrogen. So let's throw in some testosterone replacement. There's all sorts of things we look at when we're determining what we give you, and I'm not going through all this because we don't have time, but just remember when we want to give you some androgens, we use something called a high ratio of androgenic to anabolic effects. In other words, we want to give you the androgens instead of and a little bit anabolic to build you up. And compounds with a reduced androgen to anabolic ratio are preferred for anemia and osteoporosis. So the anabolic builds you up, gives you more red blood cells. Sometimes we'll do that. And to reverse protein loss following surgery. So we're looking at these what we call anabolic steroids. You hear about them all the time on the radio. Athletes trying to take anabolic steroids to do what? Build them up. Mm-hmm. So the dose of illegal androgenic anabolic steroids is 10 to 100 times higher than the dose the doctor prescribes for low T. You hear that on the TV all the time. Do you have low T? That would be low testosterone. So we've got testosterone we give you in a 1-to-1 ratio. Methyl testosterone, 1-to-1 ratio. Floxymesterone, which is 1-to-2. Oxandrolone, which is 1-to-3, 1-to-13. So these big ones here. The nandrolone are the ones that the athletes take. They have the biggest anabolic ratio. Big anabolic. That's what Barry Bonds and Roger Clemens and Marion Jones and Lance Armstrong. big anabolic, builds you up, muscle, muscle, muscle. First described in use, so we can go through this, in 1938. Actually used pharmacologically by our Olympic athletes in 1958. It was approved. You could do it. Soon discovered, though, that the more you took, the more your testicles did what? Shrunk. These guys look great above the belt. Take their clothes off and there's nothing down there. Everything shrinks. Finally banned by the International Olympic Committee in 1976. So for 20 years they were supported. All right, kids as young as 10 are taking them these days. So these are being used in schools. And girls now are taking steroids to make them look better. So boosting muscle strength, decreasing your fat stores, giving you energy, but they also prematurely stop you from growing vertically. So you'll then get shorter kids. She's taken just a little too many, but steroid use in girls have increased by 300%. Why girls? To look slender and muscular. That's not slender, it's muscular. A lot of girls that do bodybuilding take these. Yeah, so you can't get that without help. You just can't. And boys take it to improve their athletic performance, and big muscles get the girls. That's what they say. They have bigger muscles, they get the girls. She must get the girls too then. All righty. Side effects. Depends on the length of use and age exposure. Again, lots of muscle mass. And one of the most telling things that kids are taking these is a lot of acne. Now, boys get acne anyway because of the testosterone. But you take more of this. It's not just your acne on your face. It's across your chest. And a real telltale sign of taking steroids is when you get the pimples on the back. So if they got a lot of acne on their back, most likely they're taking exogenous androgens, anabolic steroids. All righty, so that being said, in women, makes you more like a man, enlarges your clitoris, you become bald, permanent deepening of the voice, temporary decreases in your menstrual cycle. You could confuse it with PCOS. So you got to ask specifically. They're looking more like a man, they're sounding more like a man, there's more virilization, could be. Okay, guys, listen up. The adult penis does not grow with steroids. It actually can decrease in size with exposure to high doses. So a lot of those athletes actually don't, as I said, don't have much below the belt. So adverse effects are decreased sexual function, infertility, testicular atrophy. You know, the more you put androgens into a male brain, too, we have what's called roid rage. I'm sure you've heard of this a million times, and we certainly see this with all the athletes that are in the public eye that are killing their girlfriends or getting angry and throwing them out of a truck or doing something crazy. They can make your brain chemistry change as well. So this is a very bad side effect. We also know that it can increase your high blood pressure, but don't forget, so does Red Bull. A lot of people are drinking a lot of that stuff, you all, and those can really cause hypertension. What's that other one? Monster. The Red Bull, there's a lot of those out there that blood pressures can go pretty sky high. Also, don't forget high blood pressure with chewing tobacco. A lot of chewing tobacco contains licorice, and licorice is a sodium and water retainer. So it acts like aldosterone. Okay, accelerated heart disease, premature baldness, roid rage, violent behaviors. So manic behaviors with these drugs. Side effects. Effects fade away slowly after drug withdrawal but may persist for at least 3 months in some patients. Mood swings. These kids are just acting abnormal, craving steroids. And then there's a few other things here about testing. I'm not going to go into this. Y'all can read a little bit later. But obviously we can test for elevated creatine. That comes from muscle. We can also do hematocrit and hemoglobin because they're building too many red blood cells, so those will go up. So we check their hematocrit and hemoglobin. Then we look for, we also have talked a little bit about something else. We're switching gears here with androgen deprivation therapy for cancer. We use some other drugs for this as well. And then I just want to run through the kidney real quick and then the pancreas. I'm almost done. Last but not least, we have one portion of the kidney that is endocrine, and that portion is to produce erythropoietin, you all. And you know this. This is a hormone. So what does it do? Stimulates red blood cell production in response to hypoxia. You don't have enough oxygen, erythropoietin says, I can help. Pushes out the hormone, goes to your bone marrow, and stimulates the red blood cell production. So, EPO levels are quite low in the absence of anemia, so they're low. You don't need them. Once you're hypoxic, the EPO production may increase by 1,000-fold. Renal failure is how we use these. Years ago, before we had this, in order for our renal failure patients to get red blood cells, we'd have to give them packed red blood cells. We'd have to give them transfusions. And in those days, we couldn't test for hepatitis A, B, C, D, E, F, G. We couldn't test for all the different viruses that we would give in these. So people that had renal failure had all sorts of hepatitis and cytomegaloviruses and Epstein-Barr viruses, all of which were given through blood transfusions. And in today's world now, all we need to do is give them a little bit of Epigen or Aranesp, any of these kind of what we call EPO products. Okay? But one last, anybody work with renal failure patients here? Okay, just quickly, you do not want to pump up their hemoglobin to the full amount. We learned the hard way. If you pump it up to the full amount with these drugs, they have a higher risk of thrombosis. And the higher risk of thrombosis means that their shunts become clotted. So we don't want to do that. It's hard enough to get a shunt in them. Let's not get them up that high. Okay, and then of course synthetic EPO is used by athletes. We know that. So we can test for this now. Lance Armstrong, the biggest liar on the face of the earth, swore up and down he never used this stuff. He used it all. He used every single one of it, but he was brilliant in the way he did it. Okay, and then of course the endocrine kidney is vitamin D production. So major job is to absorb calcium and phosphorus. How much vitamin D do you need a day? Well, it depends. If you follow the government's recommendation, the only thing they say there's evidence-based medicine for is the prevention of osteoporosis, and that's 800 a day for adults, 800 international units. That's the only thing that has been proven with evidence-based medicine. However, if you watch the literature and talk to every other doctor in the world that's working with vitamin D, they say that around 2,000 to 4,000 a day for adults is a better number. Now, if you're only on 1,000, that's fine, but I'm just saying everybody's pumping it up to 2 to 3 to 4,000. If you have MS, 6,000 a day. If you have Crohn's disease, 4 to 6,000 a day. We see that this helps people with autoimmune disease, pumping up their vitamin D. A lot of autoimmune diseases tends to be in people who are from northern parts of the world, like Sweden and Finland and Norway and Canada. These folks all have and are born with what? Low sunlight. So we see a lot of Crohn's disease. #1 country in the world is Canada for Crohn's disease. MS, European, Northern European. Type 1 diabetes, Finland. So a lot of these autoimmune diseases are vitamin D deficient diseases. All right then, last but not least, and I promise this is it, the endocrine pancreas is the part of the pancreas that produces your insulin and your glucagon. What can go wrong? Sugar diabetes. So we have an epidemic of diabetes in the United States, as you know. Diabetes, sugar diabetes, touch of the sugar. We are now down to what's called type 1 and type 2 using Arabic numbers. We started out with juvenile onset. You got it at 14. If you were an adult over 40, you had adult onset. Well, that screwed people up because some people that were 40 had juvenile onset and some people who were 20 had adult onset. So that these names make no sense. They said, let's change the name. So if you start out with a diabetes that requires insulin, you were called insulin dependent. That was brilliant. If you didn't require insulin, you were called non-insulin dependent. Unfortunately, those who were not insulin dependent, finally their pancreases gave out and they then had to take insulin. So now they were insulin dependent and they would say to me as their nurse, am I now called an insulin dependent diabetic? No, you're not. You're still a non-insulin dependent diabetic even though you're dependent on insulin. Huh? What you start with is what you're going to finish with. So, well, that doesn't make any sense. Right. So they said, let's change it again. So the powers that be, the hypothalamus, that sit up in the top of the building, decided to change it to type 1 and type 2 with Roman numerals. Unbeknownst to the people sitting up in the top of the building in the penthouse, most Americans have never had a Roman numeral class. Seriously. So, a woman comes into me one day and she said, I have diabetes. I said, what type do you have? She said, I have type 11. I said, no kidding. She said, yes, where's 2 through 10? I said, well, you were one of those fortunate ones. You skipped those. You went from 1 to 11. So I wasn't the only one getting that. So they said, oh, my God, we got to change that again. So they changed it again. Now we're what? Type 1 and type 2 using Arabic numbers. But there's type 1A, there's type 1B. There's type LADA, there's type MODY, there's type 2. There's a zillion different types. I know. All we know is it's a problem with what? Metabolism. Protein, carbohydrate, and fat metabolism. If you don't have any insulin, you're called type 1. If you have insulin resistance, you're called type 2. And you still are making insulin, but you're not making it normally. So this is called beta cell dysfunction and insulin resistance. Will you eventually stop making insulin when you're type 2? Yes. Will you eventually have to go on insulin? Most likely. In fact, a lot of diabetologists today say, let's start type 2 people on insulin. But that's not everybody's going there yet. Okay, so type 1A is autoimmune, type 2 is insulin-resistant beta cell dysfunction. Treatment is what? Drugs. Say yes to drugs. So, replace what's missing. That would be insulin. Do you know how many good insulins we have out today compared to what we had 40 years ago? 40 years ago, we got all of our insulin from the farm. We had bovine, porcine, asinine. Pick an animal, pull its pancreas out, crush it up, and we give you the insulin from that animal. Chicago was a major city because of our slaughter, our stockyards. We had trains going from downtown Chicago, the stockyards, straight into the Eli Lilly plant in Indianapolis. The train literally delivered all the pancreases right inside the plant when they first started making insulin. Unbelievable story. Fascinating story. All right, anyway, we're not using those anymore, you all, so we make it all in the laboratory. Boost what's left. We use oral drugs, sulfonylureas plus insulin. Decrease the breakdown of stored sugars in the liver and boost insulin receptor sensitivity. That's that beautiful drug called what? Metformin. This is such a fabulous drug, we should all be on it. There will be a complimentary handful on your way out today. It helps prevent breast cancer. It helps prevent prostate cancer. It reduces your weight if you're on prednisone. It reduces your weight if you're on atypical antipsychotics. It boosts neurogenesis. It treats polycystic ovary syndrome. This drug has a multitude of functions. It's a phenomenal drug. And it's cheap. Only 2 side effects. One, all the sugar is presented in the GI tract to bacteria. Puts the sugar in the GI tract. The bacteria say, woohoo, let's turn that into methane. So what's one of the big side effects of metformin? No friends. Good news is you take it at night. So if you get a lot of gas at night, you just blow your husband out of bed. If you're both on it, you can blow each other out of bed. Then the other side effect, of course, all that sugar in the GI tract also causes you to have an osmotic diarrhea. So a lot of diarrhea, but that tends to go away. So, it's a great drug. All right, now we've got some new ones out. I'm going to finish with this, and I want to give you a very big word of warning with these drugs. They're good, but we're also got a little bit of a question mark. They're called your incretin mimickers or mimetics. Incretins are released from the small intestine to boost insulin after a meal. We have shots that we can use for this called Byetta, Bidurion, which is longer acting, and then the second generation, Victoza, which is the drug that Paula Deen is on. Was anybody surprised when Paula Deen got diabetes? Hi, y'all, I got diabetes. Well, now she's on Victoza, and she's lost 40, 50 pounds because that's what that drug does. You lose a pound a day in some instances on Victoza. Okay, but let's not all run out and get Victoza right now. We also have a group of drugs that inhibit the enzyme that degrades the incretins, so it keeps the incretins up so you can produce more insulin after meals. And those drugs are all called your gliptins. You're familiar with them because a lot of people are using them now. Sitagliptin, saxagliptin, Januvia, Onglyza, Tradjenta. These are all of your gliptins. Okay, my word of warning, and then I promise I will be done. We are really looking more now at what these gliptins are doing and the incretin mimetics with the pancreas. And the pancreas, a lot of these patients are now coming down with pancreatitis on these drugs. So do not ignore, if they say to you, I've got severe abdominal pain, you got to think of the pancreas if they're on these drugs. And a study I just read 2 days ago, when people die that have diabetes that are on these drugs, we're actually seeing that their pancreases are having hyperplasia, meaning the growth of cells. Hyperplasia, if you're growing cells, you might have a higher risk of pancreatic cancer. So don't leave here and say, Barb says these drugs cause pancreatic cancer. We're not there yet. But there's some rumblings that these might actually not be quite so good in terms of their cancer properties and their pancreatitis. Can pancreatitis kill you? Yes. So I just want to give you that word of warning. I am finished. Thank you for coming to Endocrine today. It's been a pleasure. Hope you enjoyed it. And I will see you in the fall. I know there's some of you all see in the fall.